Joel Coopersmith. I'm the Director of Veterans Initiatives at Georgetown, and just to give you the benefit of my experience running the VA Medical Research Program, part of it with John, some of the time for 8 years. First of all, you mentioned the view of the major politicians. Their view often is to develop a moonshot type program. And that works pretty well for applied science, but does not work, I don't think, for basic science, where advances are a kind of a happenstance of knowledge spreading around and new techniques being developed and that sort of thing. And if you look at every one that's been successful, it has been in applied science, I think, or almost every one. Secondly, nobody has used the word health services research that I heard anyway. And when you're talking, of course, about databases and things of that nature, you're talking about, in part, health services research, which is very different from other kinds of research. And one of the issues in health services research is that many of the researchers in academia, particularly, are working on things that are never applied. Mm-hmm. And the purpose of it, of course, is to be applied. We, at the VA, we created a program where to get grants and to get funding, you had to speak to hospital administrators and develop a program with them. And I think that's worked pretty well over the years. But there is a cultural difference there. Hospital administrators expect things to be done quickly. They're have different kinds of concerns often. Researchers work on a different kind of time scale. I just want to say one thing about the development of researchers in the future. I have noticed in some medical schools, certainly not in mine, but in some medical schools, admissions committees are not very friendly to applicants who are interested in research. They want other kinds of, they're more focused on other aspects of being a physician, which are very important. But I think that's something we have to work on.
Yeah. I'm sorry.
Can I say something?
Janet wants to come back to this point. Janet?
Well, I agree with Joel that, when you're talking about quality and you're trying to improve quality, you have to have sort of continuous quality improvement. You can't have people studying quality over here and then somehow it'll miraculously improve over here. So I totally agree that that kind of health services research or any kind of research that's about the quality of care that's delivered needs to be integrated with actually improving the quality of care. Otherwise, we're not going to get anywhere. And that's true of any human endeavor, really. You have to link those two things. So I think it's a very good point.
Well, also patient-reported outcomes. Those are really capturing them in a meaningful way. So it really, you capture that is incredibly important. We haven't talked at all about that, and that's if patients are going to make choices, or physicians or health services, you have to understand the balance of quality of life metrics and other issues that are important, availability, toxicity, things that we haven't even begun to talk about.
Maybe just briefly that we dissected why certain projects work, the large public-private academic relationships that I described. The intersection was not only the academic interests of the researchers, the social interests of the government agencies, NIH, CDC, AHRQ, but an operational need in the health system. And so I think that convergence may be the secret sauce and an accelerant.
Yeah. David Sklar. Traditionally, we've had a long history of trying to get our trainees, residents, and students to participate in research as part of their educational programs. And I think, as you've mentioned, the outcome in terms of them actually turning into researchers is probably not very good, or not what we would hope. Even MD, PhD programs, a lot of the graduates end up doing clinical work and don't continue doing their research. So I guess my question to the group is, do we really need to fundamentally change how we're focusing our medical training for physicians in particular, to acknowledge that probably most of them aren't going to use sort of research skills? A lot of our fellowships now, they require the fellows to do research. Is this a waste of our resource? Should we be doing something different? Should we be maybe only having a few medical schools that take students who are interested in research, or should we do something different for all of our medical schools? So I just throw this out because I think, we don't have unlimited resources, and if we want to improve the whole research enterprise, we probably need to use our resources more intelligently.
So, can I make a comment about this? So I struggle with this a lot. I'm involved in a project to sort of rethink graduate education in science. And you say to yourself, well, if that student says they want to go in path A, do B. But the truth is, we're lousy predictors of who are going to be great scientists and who are going to be great contributors. So tracking people too early is really bad. Now, it's risky because you may be training people to do A or B and they'll never turn into an A or B. But there has to be a way. I don't have an answer, I only have a question. There has to be a way to provide people with a core set of skills and knowledge, and then, as they get closer to going out, do the specialization within the educational system. But you don't want to track people too soon, or you'll lose all those people you would predict poorly, or you would be poor at predicting.
Please.
I'm Dr. Ira Williams, Greenville, South Carolina. I've written 3 books on the healthcare delivery system. And I'd like to give you a rapid walk through the history of the efforts to improve patient safety, beginning with diabetes, seeking to quantify medical care. And IOM created in 1970, AHRQ in 87, Brennan and Leap in 90 with their estimate of needless hospital deaths, and Terror is Human, and on and on. And where do we find ourselves today? In this room, we find a high level of frustration. And I believe much of that frustration is due to what I refer to as the 2 greatest healthcare mistakes regarding the delivery system. First mistake, the erroneous use of the word system. Terror is Human and Elizabeth McLellan in her RAND Corporation 2003 or 2004 study both recognized the system to be a non-system, but we have never recognized the critical importance of that recognition, and we continue, every time you use the word system, you're talking about something that is devoid of any systematic characteristics. Second mistake is the failure to recognize each state's responsibility. And I'll give you 3 fundamental facts. All medical care is local, states licensed doctors, and all 50 state medical examining boards are each over 100 years old, and each one was created to regulate the practice of medicine. I predict it will be impossible to ever create a 21st century healthcare delivery system worthy of that label without recognizing and incorporating into that process each state's responsibility. I believe when Ms. Woodcock talked about regulators and how to, state regulators are closer to the point of medical care than any federal regulators. And look where we are today. So I would like to leave each of you with a 2-part challenge. Seek to describe in detail your state's healthcare delivery system by naming each component, describing in some detail how they function, and then seeking to identify any systematic characteristics. In 2010, I described the South Carolina healthcare delivery system having 16 components, and they each function as though they each spoke a different language. Now there are 18 components because we've gone from 2 medical schools to 4. At the same time you try to describe your system, see if you can identify even one person in your state who can claim the ability to do that now. And I think until we recognize the system is a non-system, and until we recognize each state's responsibility, we will continue dealing with extreme frustration.
Maybe just a quick comment on that. I think one of the reasons that Lou Sandy and others were so pointed about data as an underlying principle is that it has the unique capacity to confirm systemness on an environment that, as you point out, is fragmented.
Good point.
And not only fragmented, but increasingly complex to the point of non-comprehension and comprehensible complexity. And, you know, in terms of system design, whenever you get to a situation like this, it's very true that every part of the system is going to try to make rational decisions based on their local conditions, but there's no mathematical proof that the sum of rational decisions is a rational outcome. In fact, we've proven the opposite, so I would agree with the complexity. Yes.
Thanks. My name is Eva Powell with Common Purpose Health, formerly of Evolent Health and the National Partnership for Women and Families. And one question I have is just, we've talked a lot about workforce issues relative to academic medicine and the actual practice of medicine. I'm wondering if there are efforts going on to reach outside of healthcare, because there is a dire need for expertise and workforce in other areas. And I know from my work at Evolent that always, for everything that we have tried to do from an operational standpoint, which is actually what we are all hoping to get to, the rate limiting factors are always IT and analytics. And those are two areas that are traditionally not healthcare areas necessarily. But without those two things, we will never bring all of this great knowledge that we're talking about and that we're going to develop in this room as a result of the academic work to the actual patient's bedside.
Actually, this is a specific recommendation we're making, and this is the point that I was trying to tie to Jonathan and Janet's points about the need for training in data sciences and bioinformatics and all these new specialties, in fact, that need to percolate the entire medical, not only medical, biomedical, biological sciences. So we have recommendations actually in the text that says that whatever the initiative is that is adopted or followed, it has to build on, you know, other reports that the National Academy had, the Gathering Storm report, the STEM, but also focus on creating a workforce we do not have today.
Correct.
And by having the positive incentives that we need to create for those, and it's in the report. So completely agree. Keith?
Keith Yamamoto, UCSF. I just want to try to comment on two of the points that you, Elise, have raised and your panelists have commented on. The first, the bottoms-up, top-down directives of the way that we do research coming from the federal government. And I should, maybe by full disclosure, say that conflicted in both directions. I got my first R01 grant when I was 30 years old. A couple of you know how long ago that was.
Last year.
Yes, that's right. And I've also been deeply involved in some large initiatives, precision medicine, trying to move that toward and get the president's attention and make it into a presidential initiative. So I believe in both directions, and I don't think they need to be conflicting. So I want to argue a little bit with what Alan said in response to your question of how we choose such initiatives. And what he said was pick winners. I know Alan well. I know he didn't, that was shorthand for a lot of other things he's thought about in this realm, but I'll just say that I would disagree with that formulation in the sense that I think a well-constructed and formulated big challenge is one that actually chooses and enunciates a problem that has no current solution, and thereby challenges people across a broad spectrum of science to think about how they can contribute to solving that problem. That is a well-enunciated grand challenge of sorts. Widens the tent of people who get involved in it, and it would include those who would be simply thinking in a curiosity-driven way about a question that they think that they could answer that would contribute to that challenge. If you think about the first moonshot, the 1961 enunciation by President Kennedy. At that time, the United States was having a hard time getting rockets into the sky. Forget about taking a man to the moon and back, right? And what happened was that the whole community kind of grabbed onto that challenge and said, wow, I could do something that could make a difference. In 1990, when Bruce Alberts chaired the National Academy's report that said, let's go sequence the human genome, we had no, we were using gel plates and Maxim Gilbert sequencing and trying to get 40 base pairs. There was no way to get 3 billion. And the question activated a community to think about how they could go after the problem. So a well-enunciated grand challenge that broadens the tent and includes people using their own imaginations and curiosity to contribute to its solution is actually something that allows us to actually move in a direction to take on an urgent issue. And so I think that they don't necessarily conflict. I think it's something that you might want to comment on, and I suspect that Alan agrees.
I do agree.
Using shorthand.
Yeah.
So
I will never use that shorthand again.
The second was in training, and both with respect to the imperative that we have to broaden the way that we're training, and Ellen's point about the ways that we're kind of putting the product on the shelf. I actually believe, and some of you may have heard me say this before, that we have taken, our community has been able to take one of the most important, compelling, exciting, enduring human endeavors, that of biomedical research, and make it look terrible, make it look pedantic and long-term and never-ending and no chance of success. You know, it wasn't easy, but we did it. And we have to change that, because it actually is all of those wonderful things. And it comes at a time when we need to be broadening the way that we're looking at the whole field of biomedical research to include computer scientists and physicists and engineers and chemists. And that's a great opportunity to say, look, here's what the new field is, and we can really move forward in this way. But we haven't had academic institutions step back, and I hope that Alan's Academy study is going to do this, and ask, what is it that we're actually providing in our training? Are we giving them in their back pocket when they walk out of our institutions with PhDs the kind of information that arms them to be really successful in this new 21st century mode? And I think that we have, academia in general has not thought about that. We tend to put one foot after another. You know, my course got good ratings last year, so it must be a good course. Let's teach it exactly in the same way. And that's predominantly the way we're thinking about education. So I think we should take this as an opportunity, the obligation or the imperative we have to broaden what we're doing as an opportunity to redefine, right, not only the scope of what we're teaching, but what it is, what is the content? Are we really teaching them to really identify an important problem and think of experimental approaches to solving them, and knowing what an answer is, and knowing what direction to go with each answer on the next experiment and so forth? I don't think so. So I think we've got a real opportunity there. And so we should take this need to broaden what we're doing as a real opportunity.
Thank you, Keith. I don't think anyone will dispute the need for change. The question is how. And how do you pilot, Keith, these new experiments, especially when we have to be young scientist-centric rather than system-centric. And to me, what was really great for me was the fact that I was given a chance to go into biomedical engineering and biology, and my boss was really flexible. Say, well, go take 3 months and go do this, and go take 5 months and go do that. It's not the case today. I think most people say, well, no, the credentialing requires you to do this, this, and that, and 3 years of that. And then it becomes like a cookie cutter type of education. And to go back to the question, should we, as a government, as a next gen or a new approach, encourage and fund pilots that are innovative pilots in academic institutions? Because, you know, having been a dean and a chair, I can tell you the resistance to changing the lines of authority for training are as important as the funding mechanism. So to me, it seems like that's a recommendation that we should enhance based on what you just added to that, the need for
But there are new models of innovation, and if you look at these large-scale philanthropists or groups that are merging people to work together, they're doing it outside of government. They're doing it outside of and they're forcing the academic environment to collaborate. You know, whether it's Stand Up to Cancer or the Sean Parker Initiative or others that are being formed right now, they're basically saying the old model doesn't work. It's rigid, it isn't innovative, it doesn't integrate, and it's not goal-driven. And the young people recognize that, and they're changing culture, and they're forcing cultural change. And maybe that's what it's going to need, because you're right. Within government and within academic structures, it's extremely difficult. I can tell you, I work on clinical trials all the time, and just getting scientists to ask the right questions, not important science questions, but patients that are relevant to patients. At one point, one of the trials that I worked on, I said, nobody will accrue to this. Well, it's an interesting question. And I said, to who?
Good point. Sir?
Good afternoon. Umair Shah, I'm the Executive Director of Harris County Public Health in Houston, Texas, County Health Department, and I'm also wearing a second hat. I'm the President-elect for NACHO, the National Association of County and City Health Officials. I find this panel to be fascinating, as well as the earlier panel this morning. And what I would say is that one of the big things that's happening in public health is this real move towards innovation, engagement, and really social determinants of health and health equity. And those three areas are really cornerstone for how public health, especially at that local state levels, are really moving forward, and obviously supported by our federal partners. One of the biggest challenges that I'm seeing as I'm hearing the discussions here today is that it appears that we're talking about innovation, science, technology, engagement, all these things, oftentimes on that healthcare space, and then we're also maybe thinking about that on that public health space. And what I really think is the most critical piece is the actual intersection of that public health and that real outside of the healthcare system, the community health perspective and what's happening in healthcare delivery. It's that intersection point where innovation and integration and really thinking about how we can bring things together so that the healthcare providers like me are also thinking about population health, and on the other hand, when I'm wearing the other hat of population health or public health, that I'm thinking about healthcare delivery, and we're bringing that intersection point together for innovation. And I'm not hearing that as much. I'm hearing it still as a bit more of these two spinning wheels, but not necessarily bringing them truly together. And I just wanted to advocate for trying to find an intersection point, especially around innovation and obviously community engagement, oftentimes thinking about not just what's happening within the four walls of a clinic or a system, but actually getting out into the community and really where health really happens, where we live, learn, work, worship, and play. And so just wanted to challenge us to be thinking in that broader sense, but also specifically that intersection point as being a critical inflection point, as was mentioned earlier, is I think a really important piece.
I may have glossed over it, and I know the next entire panel is on health and well-being, but when I mentioned the importance of end-to-end interoperability, a large part of that really is to support population health in the true sense of the health of communities. And realizing that good measures of community health are not simply the aggregate of personal health measures, but have everything to do with community determinants, as was eloquently outlined by Mark McLellan this morning, in terms of any number of other issues. We are at a cusp of realizing opportunity in the healthcare delivery sector. I would suggest we're also at the cusp of realizing an opportunity in terms of using data collaboratively that address both health care and health and well-being in the community. And that has to be a priority agenda. If for no other reason, then you think that, well, one answer is being more efficient in terms of taking care of the individuals with concentration of chronic disease. When you get to first principles, it's really promoting health and avoiding those end states.
Thank you. Just one other, if I could just add this last point from a local perspective, that we're having the conversations locally about population health. And so we're finding when we're going to our practitioners, they're thinking their own practice, the population, and the health insurers thinking their population, and really thinking about the broader population health, which is what oftentimes public health is front and center about. And really, I think, really not saying it's an either or, but an and really trying to find ways to intersect that as well. So thank you.
That's a very well said. If you have any particular language or suggestion, please pass it on, because I think this aspect has been discussed. But I don't know that any one of us has a good grasp of how to do it or how to integrate the strands of because innovation has multiple dimensions, as you know, of the training of the workforce, the regulatory, the data, into a coherent vision of its impact on the different stages of innovation, from the target discovery and the validation of the clinical trial to the impact on the population. I don't think we have at least we should work on it, Victor, is to try to create a framework perhaps for this section.
Next session.
Okay. Okay. I'd like to remind everyone that we are on webcast, and there will be some questions that could be coming from the webcast members that we will summarize, but in the meantime, we'll stay with our present questioners.
I'm Jackie Campbell from Johns Hopkins University School of Nursing, and I want to bring the perspective of some of the women that I work with in terms of both research and patient care. These are the women that are in those zip codes where their life expectancy is shortened. They are raising children in incredibly dangerous neighborhoods. And when we talk to them about, why don't you go to this website and fill out these forms about your health care, and they have a cheap phone. They don't have a fancy phone like we all have. They have a very cheap phone with very few minutes. They're like, don't send me a text. I don't want to use up my precious minutes on some stupid text from you every other week. And I certainly don't want to be driven to some website where the only internet capability I have is to go to our local library, where I have 1/2 hour max to do anything on the internet. And no, I don't know that you can reach me by this cell phone number in 2 weeks, because I have trouble paying this bill. And I'm going to get a different number. I don't want my numbers to follow me. I'm going to get a different number. And no, I don't know for sure where I'm going to be staying in a month. Me and my children may have to, we have terrible housing insecurity. So when we talk about getting these incredibly important citizens, the ones for whom health inequity is the worst, the ones for whom our healthcare system, my wonderful Johns Hopkins, is another example of structural racism, where when I go for a patient encounter, it's another place where I'm put into a situation where I have many microaggressions that contribute to my stress, that contribute to the trauma I have experienced since a child. And so, you want me to come back and see you? Well, that's a real, important decision for me to make in terms of, do I take time away from whatever little job I can get, time away from childcare, difficult transportation, and then when I get there, my perception is that you will treat me as lesser. So both in terms of our research, our electronic medical records, the data we're trying to collect, I think we need to be really, really mindful, and that it builds on what was just said in terms of how we are perceived as a healthcare system, and also in terms of the terrible toll that racism takes on the communities that we're trying really hard to increase health. So there probably wasn't a question there.
That's a question.
No, clearly that's a challenge that all of us face. I'm from Hopkins, so I know exactly what you're talking about. Then And capturing data, to me, is not just in a positive sense. If you have a patient where you're not capturing data, that in itself is revealing. And that's why I think Jonathan is right in saying we need a comprehensive, longitudinal record of both the health, but also the environmental factors over a period of time. Because you can say that, for example, Tom Insel from NIMH, believes that the activities recorded on an iPhone actually are a good indicator of the state of depression or mania that manic depressive patients have. And that's an idea where, in fact, the interaction between you and the system is in itself an indicator of need. So I think it does mean that capturing reality may, in fact, help decrease both disparities as well as bias-driven changes, poverty-driven, lack of access, and so on. But I think it's in my view, it's a subject of, it needs to be a subject of study with different tools than what we have. And it reflects the data that Mark McLellan was showing this morning, where our proportion of spend on healthcare relative to social services is out of whack. These kind of situations in other countries, and this is where I advocate comparative healthcare system analyses. Having been international in nature and knowing Europe and having parents who were treated in those systems, I wonder if there shouldn't be a field of science called comparative healthcare analysis. We tend to look at ourselves and correct ourselves with our own, but other people have often solved that problem with direct social interactions with home nurses and so on and so forth, which we need to learn from. So that's part also of the recommendation of understanding healthcare delivery system. So, sorry, thank you. We need to leave some time for the webcast folks, so I'd ask you to be brief if you could.
Yes,
it's a one floor elevator.
Yes, one floor elevator. Bob Phillips, American Board of Family Medicine, and serving on the National Committee on Vital and Health Statistics. I want to get past moonshot to International Space Station. So there are many countries around the world that are more than a decade ahead of us in terms of dispersing electronic health records across the system and now using the data. Right. The Netherlands, the UK are far ahead of us. I discovered in New Zealand that they have research centers, particularly the University of Auckland, bringing together inpatient, outpatient, ecological social determinant data, tax data for social determinants, census data, and they're bringing them together to look at and create new models of decision support, Framingham study writ large. And they're also creating research data centers around the country so that other researchers can come and use those data without walking away with them. And I wonder if we might advance our science here much faster if we could actually send some of our researchers there to work with those data sets. I mean, those are clinical and health services research dreams that would set off huge alarm bells here without having an experienced workforce of working with them and figuring out how to protect them. And it might be a nice way, almost like a Fulbright pathway for researchers here to go develop the experience in their younger years.
Well said.
Would note that one of the recommendations in the interoperability paper was to really address some of the barriers to data sharing. Because what you suggest is more of a political, financial incentive and policy issue than it is a technology issue. With that in mind, as proud as I am of the reduced MRSA being conducted in 18 months, there's a thought that both terrifies and tantalizes me. What if, by virtue of the random variation in the different arms of the three-arm comparative effectiveness study, that answer was already embedded in the data? And what if doing that research in silica might have taken 18 minutes, not 18 months? So your point is well taken, and that's why I think, to the President, this opportunity is so incredibly compelling.
Hi, Elias, a great panel. Peter Pronovost, also from Johns Hopkins, and great discussion. And Alan, you alluded to, and recognizing I come from a basic science institution, but when I look at the data, it's quite overwhelming that the linear model of research that we've been embedded in since the Vanderveer Bush report in 1942 of basic to clinical to applied is not where great breakthroughs coming. I think, and it's something we probably need to grapple with, that the great breakthroughs seem to be coming when we solve problems and puzzles together. As we create a Bell Labs aligned around a purpose or some key principles of behaviors and mix up different scientists together to solve a practical problem like putting a man on the moon or population health, and through that also make advanced discoveries. And I would love to see some recommendations of funding those kind of Bell Labs that aren't just hospital-based, but bring in population health or these other things, and then potentially the implications of that model on the workforce, because what I see to work in that kind of Bell Labs, we need to train what I call jellyfish rather than teas. In other words, our training, and I'm a product of it, is very deep methodological grounding in one thing and almost nothing in anything else. So I can't even communicate with an engineer or a social scientist because I don't know their language. And I think we need to begin to produce people with, yes, you need a methodological grounding, but you also need to be curious enough to have a lot of short tentacles to know when another discipline could pull your levers in a more meaningful way to move the needle. And it'd be great if we could perhaps think about what structures we might support to keep those transdisciplinary teams together.
So it's interesting that a number of organizations have done the experiment in facilitating translation by juxtaposing people from all the different places that Janet and Ellen referred to, where they have clinical scientists and basic scientists and whatever, and the data are very clear. What you just suggested is a great idea. That is to bring people together, train them how to talk to each other, train them how to collaborate, et cetera. Convergence, right, interdisciplinary science. The problem is we don't seem to create the policy environment that facilitates that. It's not just that the old guard of academia doesn't want to play with other children. It's that, in fact, the policy environment says if you put academicians too close to industry, oops, you may misbehave. And the same is true in training. We don't want to tarnish a pure chemist with putting him or her together with a sociologist, God forbid. You know what I mean? But the experiment's been done. It does work. It does make things happen better when they actually live near each other and are forced to talk. It
does relate to a point that Ellen was making. I mean, fundamentally, what we're seeking is a culture change that promotes collaboration with folks that we don't usually interact with. And that's really what the system is going to need.
So, Elias, industry can do it, philanthropists can do it. Can the government and can academics do it? Because it's so rigid and the culture is so difficult to change. I mean, it will have to take an external force to do this because it's really hard within any academic environment. It's very difficult. Even within government who wants to, we do public-private partnerships at the NIH, and changing culture is really hard. So in industry, you can make this decision easily. If you're a billionaire, you can certainly do whatever the hell you want. But can our existing structures change rapidly enough to integrate this? Because we all know it works. And it's not only works, it's essential.
Yeah, we have difficulty in the government, even I have trouble convincing our HR people that it shouldn't be like a tier of pharmacists and another pharmacist on top of that and then another pharmacist. And I keep telling them they're multidisciplinary teams, that's how we do things, but that's not how the HR system works in government. So there are many, and I think in academia, I think it's what I was alluding to earlier, you need people who are trainees in your laboratories or your whatever to do the work. And so they get to be trained in that thing because that's what is needed.
It's a very important point that you're making. It's almost like we need HR innovation. Because I think, Keith was with another group talking about the increasing burden of administrative and bureaucratic duties imposed on scientists because of the failure of the system to accommodate the need for maximal efficiency, if you will. It's a very important point, this HR innovation requirements that we need to
We did that for cancer at the FDA, and there was a lot of opposition internally. No, statisticians know this, and diagnostic people know this, and by forcing them to work together, it will create change, and I think this is, but it's not easy to do.
Hi. In the earlier discussion, the panel talked a little bit about how difficult it is to get the research grants. So my question is, other than funding, is it the application process itself that needs to be improved, or what would you say are the chief barriers?
Depends what grant. Is it good enough or not? You know what I'm saying? What grants? I missed that comment, so I can't respond.
I was saying for research grants in general, because you talked about how long it takes for a lot of researchers to get their first grant.
So I think there are systemic issues that have been created. For example, I was surprised to find that when I was Dean of Research, that if you're a postdoc, you cannot apply for an NIH grant. And since you're a postdoc until age 35, 36, and you're not appointed as an assistant professor until age 38, you can't apply for a grant, and you won't get one until 42. So it's not an NIH issue. It's really a career rigidification sclerosis, and I'm sorry to use provocative words, but I believe them.
Absolutely.
We have essentially created over the past 25, 30 years. As the baby boom generation came, there was a void, and it got filled, and then as that is filled, they're not retiring until 2020, 21, there is basically a collapse of the number of positions available, and so people still keep staying in the system until they're 36, 37 as postdocs, hoping for a position, and then they can apply. That's one. The second is what I think was mentioned, the fact that the peer review system is supposedly age blind, color blind, and gender blind, and so on, and yet it isn't. And so we need to really be also cognizant of the fact that a young investigator who comes in may not have all the preliminary data that a senior investigator would have. And so I think all of those forces are coming to a point when we say NIH is peer review. Remember, peer review is done by academics and industry scientists. When we say, oh, well, the career of PhDs is too long, only 36%, 99% are older than 36. Well, remember, the age of tenure track position appointment in academia has moved from 28 to 38. You don't get to be an assistant professor at 28 anymore in most schools. So I think there are systemic issues in addition to the funding. I mean, the funding is always the big problem with funding is you have these ups and downs. Right. I think when you have an up, the NIH forces itself to spend the money, gives more grants, but you don't give a grant and fund it that year. You fund it over 4 years, right? And then at the time you do this, obviously you had a great year, like the stimulus year. You found X thousands of grants, and then the next year you have a down year. But remember, you still have to fund the grants you committed to in the fat year, and then the lean years get worse, and that's when the young investigators get discouraged. The young lady who was doing 3 years of internship falls into that trough and says, it's impossible, I can't do it. And everybody is essentially living with a system that is in itself unstable because it's not progressively, sustainably funded to reflect the growth of science. And it is based on a system that I believe has become academically rigid and needs reform.
I would add something. Yeah. I mean, I think one of the things about youth is they're willing to take a lot of risks. Right. And do wacky stuff, okay? And the system, as it's built, has the elders of the tribe overseeing what gets done, okay? And so that risky, some of it is going to just be not very good, right? And some of it is really going to pay off. Some people do their best work in their 20s.
I'm glad you brought this point, Janet, because it's right on target. It's so true. When I was at the NIH, we heard about these things, say, well, let's create a different pathway called a Pioneer Award.
Right.
And the Pioneer Award was, first of all, a violation of federal rules because we didn't really follow all but we did get a pilot authority from Congress to try the Innovator Award, the Pioneer Award. And what it was 9 very established scientists who came, and there were Nobel laureates and so on and so forth. And then we said, okay, you can apply, and you come and you defended your grant in front of that committee. And you know, one of the criteria was actually to fund science that was found exciting by the committee, where the committee could not find a reason why the science could not be done. So it's not like peer review. Peer review is like any reason it could not be done, you get turned down. Right. Here is, can the committee prove that it cannot be done? Right. Not that the candidate proves that. Right. And guess what? We funded folks who were turned down 3 times on their R01s, like Carl Deserath, who in my view has been a terrific scientist, innovator and risk-taking. And then, you know, the IOM, by the way, reviewed that program. Of the first 35, 50, 25 of them were really superb scientists.
That's a good
you're
percentage.
Completely right. We need to have a sort of a risk-reward pathway that is non-conventional. I agree. Sorry. Questions from the webcast?
Yes, I have 2 questions from the webcast. The first is, how can we attract more women and minorities to science and technology? We finally have more than 50% of women as medical students, but science and technology seem to be lagging behind.
So that was actually a point also in our workforce of the 21st century. It's clear that for women in biological sciences, in the early stages, we're doing better. But when you look at positions of authority and professorships, and you find that there is a drop. So they're 50-50 at the beginning and then 70-30. So there's work to be done. And I think it's happening, but not maybe at the speed we want. In terms of minorities, it's a deeper issue because as the obstacles in the system, the rigidity of the system, cost of the system, tuition, economic opportunity, because remember, when you are saying, I'm going to pursue a career in research today, you're basically taking out 20 years of earnings. Right. You know, from age, well, maybe a little less than 20 years of earning, but from the age you and finish college at 22, remember, you're not going to get a tenure track position where success is not guaranteed until age 38 on average. So 16 years of revenue. You could go to Wall Street and as a minority bright candidate, you can basically get into an economic situation that will be much better than what your parents were in. So we got to realize that there's a career pathway management that needs to be managed. Freeman Rabowski was part of our group, and he talked about the Meyerhoff Fellowships, and where you identify students early and mentor them over to the scientific careers that you need to have. So minority training, we're competing not only within science, but we're competing between science and other fields of where there's more rapid and more certain earnings power. Those are socioeconomic issues that need to be understood and need to be worked on. We have the loan repayment program. It's partially successful, I would say. I think it becomes a subsidy more than a real incentive to a long-term research career. That's my view. It's not everybody's view. But I think we need to do better, no question. The principle should be that the diversity of your scientific workforce should reflect the diversity of the people to whom those efforts will apply to. Otherwise, you end up with what was mentioned before, where there is an asymmetry that ultimately, culturally and socially, is not something you want to promote. You want to correct that, not maintain that, because health will have to be dealt with in a fair and just manner if it is to be successful. So that's my response. I don't know if the members.
Agree.
You have a second question?
So the second question has to do with the importance of prevention. So obviously this panel and the papers argue for an investment in strong science and technology, but how do we balance or integrate the importance of prevention?
Go ahead.
I was just going to relate an anecdote from VA, is that in 1998, rates of pneumococcal vaccination were very low, order of 24%. By 2004, they were in the order of 90 plus. Rates of colon cancer detection were low for early stage, but very high for advanced cancer. By 2004, almost invariably, it was very early stage. And you know, beyond the compassion and safety and quality and effectiveness of those preventive services, it's also much more economically efficient. There's an issue I think we have to grapple with. I could not score that in the federal budget. You know, actually, Peter Pronovost is an expert in this area. He may be able to explain it best, but the return on your investment is scored annually. And we really need to take a longer view at funding preventive services because the payoff is not going to be earlier. What I think is equally compelling, and Dr. Cooper Smith and the Health Services Research Team did some phenomenal studies on this, but over that period of time, as measured by the SF-36, function went up, longevity went up, and cost per veteran went down. Now, obviously not causal, can't draw causation from that, but there's a pretty compelling correlation over about an 8-year period with the infrastructure for preventive services. So there's a convergence with the data in terms of being able to apply the science with decision support. There's a convergence with the data in terms of having a lifelong health record, as you alluded to. There's a convergence with the population health in terms of understanding not just attributed population, but the true health of community and the population in the public health sense. And there's a financial policy set that has to be addressed as well.
I just want to point out with prevention, which is incredibly important, getting that into the community is really important. We know so much about tobacco. If we could eliminate tobacco and obesity, we would have hugely different outcomes. And I don't know whether it's anecdotal or whether the numbers are coming up, but I observe more and more young people smoking, and one has to go any place and see what's happening with health and obesity. But I also want to caution you, there's a lot that we don't know. We don't know how to, in the world that I live in, there are many cancers we have no clue. Elias talked a little bit about Alzheimer's, but really we don't know how to prevent brain tumors. We don't know how to prevent many of the blood cancers. So there's a lot of knowledge that we do have, and we can do a much better job at early detection and prevention. But there's a lot of knowledge that we don't have, and we don't know how to get prevention into the community setting, and that is and the culture, huge cultural issues there as well. So it's a very big problem, but if we could do something about that, we would change healthcare dramatically.
Well, and one more point about this is that there's a structural stacking of the deck against prevention in our system. Correct. And that is that, you know, the insurers will tell you that the insured population basically rotates every 3 years. A quarter to a third of their insured change and go to another insurer the next year, another one the next year. There is no continuous risk-reward control, if you will, in the system. And so do you want to invest in prevention when the patient is insured by you, and then someone else is going to take the benefit, and then you'll take someone who has not been treated for prevention? So there's something that needs to be addressed, and that is that the economic incentives of prevention are actually misaligned in the insurance system. The second is environmental factors are essentially well known. I mean, smoking, eating, sugar, nutrition, obesity, and we have no real system of policy or except for some areas like, you know, tobacco, for example, where there is such a public intervention. Someone this morning was mentioning the need for having a health scorecard. I would say that the health scorecard has to be by political district, by a congressional district. Frankly, we had that at the NIH. We were showing actually with each district the obesity, diabetes rates, and so on and so forth. And I think it would require us to have a political impact of lack of prevention, a negative impact for that to change. Just like jobs. I mean, if you have a district where you can't maintain jobs, you tend to lose the election. And I think we need to really find a way where in our society accountability to health, not just health care, but health, is going to become a norm, not an exception. So that's my spiel on this.
If I just might play one more piece back to interoperability, it's really converging your point and Ellen's, is that for the things that we know, we certainly need to be able to apply them. But to your point, what we don't know, we always think about the electronic record and interoperability as a lifelong health record played forward. But the aggregate of that played backward is insight into what certain exposures mean, what their correlates are with any number of the omics, from genomic to every other permutation. And there's a credible convergence of population health and discovery with the health record played backward.
Michael is sending me the signal. There's one more question. Go to you.
Oh, thank you very much. Pauline Codier. I'm someone who's been in a career for trying to make a difference in people's lives, so I just wanted to bring to the table a thought about the user experience with the data and the data as information and not just data for the sake of data. We know with health literacy that if we communicate effectively, people can take action on their health. So I challenge the group to think about the user experience and think about the data that you present and think about the physician using data as a coach in his population and getting information from his patients as well as reaching out to teach them and understand how their learning is affecting their health results, because the patient or the person really is the center of this. And if we can't communicate effectively to them and communicate innovations effectively to them, then we're really at a disadvantage altogether. So I just wanted you to think about that a little bit.
PCORI's done a lot of work in that area. PCORI's done. No, I just wanted to say that PCORI's done a lot of work in that and how to communicate and patient preferences and how to do that. There's a lot of very good data, and ARC and other agencies have done that. I mean, I think that's emerging. We need to get better, but the patient experience, of course, is the most important.
Michael was giving me the eagle eye, so I wanted to just quickly thank you for sharing your wisdom and expertise as the next president, Puritan.
We would only hope. We'd only hope, Elias.
Well, and not only thanks to Alan, Jonathan, Ellen, and Janet, but to President Zahumi as well.